Sir, yes,
I must tell you that I am alone and the whole world is against me. And I must tell you that recently I am attending several Chiari conferences. Recently there were 27 speakers in Chiari meeting, and there were 26 speakers who were saying foramen magnum decompression, remove bone, remove dura, do not do this, do not do that. And the 27 speakers said that all this is nonsense. So the question is, you see, don't go by my aggressive kind of presentation or whatever, but I can tell you, I have got the answer to Chiari formation. Read the title, formation. And I want to show you my concepts. And I also want to tell you that each and every sentence that I'm going to speak is published in a reputed and international journal. I'm going to talk to you about basilar invagination, about syringomyelia, about Chiari formation, and I am saying today, definitely, positively, these three clinical entities are due to one problem, and that problem is atlantoaxial instability. Chiari malformation is a common clinical event. Chiari malformation and syringomyelia are common clinical entities. Now, is the pointer here? Chiari malformation, syringomyelia, syringobulbia can be an association. Basilar invagination, Chiari malformation, syringomyelia is a common clinical triad, common. Chiari malformation with a manifest atlantoaxial instability, manifest means it is seen, is a relatively rare clinical entity. Chiari malformation, syringomyelia without any bone malformation is a much more common problem, much more. Much more in Western countries this problem than in India. I have one question. Is the presence of basilar invagination, is the presence of Chiari malformation, is the presence of syringomyelia, are these all interrelated, or these are independent clinical entities? I must tell you that Chiari malformation was described more than 100 years ago. Nobody knows what is Chiari malformation, nobody knows. But I can also tell you that everybody knows how to treat, and their hands will go, I treat. The other problem is everybody of you thinks that you are correct. That is the problem. Everybody thinks that there is no further discussion on this subject. Now what is this happening, this time business? No, what are you doing here? No, it was 15 minutes already decided. Now why are you changing this? No, you please don't do this. Please don't do this. Because I have come prepared and I have already discussed, and now you are changing in the middle of the lecture. This is not fair. And don't do this. Because I am serious about this issue. No, this is going to be like this. Chiari malformation, nobody knows what is the etiology. Everybody thinks that the tight posterior cranial fossa is the issue and decompression is the solution. In the year 2013, I introduced a concept saying that is atlantoaxial instability the cause of Chiari malformation? This I published in 2013. And believe me, after I published, there have been several debates, and I have presented more than 100 lectures in the last 5 or 6 years. I also introduced another concept of central or axial atlantoaxial instability, meaning thereby no radiology is showing instability, but it is an unstable joint. When I wrote these papers, there have been several debates, and those who are in neurosurgery, of course, they know it. So one of these questions which are published, all these debates, one is conference debate, one is publication debates. So this is one letter to editor written against my paper. This is another letter to editor, and there are responses written. There are 6 letters to editor saying that We don't agree that atlantoaxial instability is the problem, and we don't agree that stabilization is the solution. So I want to go in my personal historical perspective as to how I come to this concept. In 1998, I wrote this paper, which is cited more than 350 times on Google search, saying that basilar invagination is a fixed atlantoaxial instability. Means basilar invagination, atlantoaxial instability may be there, but it is fixed. In 1998. According to this concept, I said that either the odontoid process can go up or the tonsil can come up. So these are the two types of basilar invagination in 1998. The issue was a fixed AAD, and the solution was decompression. Transoral for this and posterior fossa for this. This is I had described. And for the first time in the literature with basilar invagination, we had discussed that there is a tight posterior fossa. Tight posterior fossa we had analyzed. And we said that there is no need to open the dura in this situation. This was the first time. Then in 2004, we introduced a concept which completely revolutionized this field, where we said that there are some basilar invaginations you can reduce by facetal distraction. The odontoid comes down, and you know, those who are in this business, completely transoral is a historical operation. Those who do, even they understand this problem. And we introduced this kind that basilar invagination is nothing but atlantoaxial listhesis kind of solution of C1, C2 joint. Then we said another fantastic thing, that syringomyelia is not a problem. It is a solution. It is not harmful. It is helpful. And these things are published. Then came my very revolutionary article which says that short neck, platybasia, torticollis, clipple abnormalities, bone fusions are not problems. They are solutions. They are solution to one problem, and that problem is atlantoaxial instability. You understand what I'm saying? I'm saying the short neck is not a pathology. Torticollis is not a pathology. Bone fusions are not a pathology. They are solutions, and they come in response to atlantoaxial instability. And you do atlantoaxial stabilization, short neck can become long neck in the evening of operation. Torticollis can recover in the evening of operation. And we wrote in several of my articles that bone fusions can unfuse. And these are some examples. Then we said that bone fusions, these bone fusions are not embryological issues, they are secondary natural issues in response to atlantoaxial instability. This bifid anti-arch and posterior arch are not embryological issues like spina bifida here, but they are a dynamic process. They open, you do flexion, they open, you do extension. So this is a dynamic process, and it is a response to atlantoaxial instability. And all these sentences which I am saying are published in major journals of neurosurgery and spine surgery. In 2012, I came to another fascinating conclusion that all basilar invaginations, there is one problem, and that problem is atlantoaxial instability. All basilar invagination need one treatment, and that treatment is atlantoaxial stabilization. So this was my conclusion. And we introduced another classification of atlantoaxial instability on the basis of facetal instability. Facetal, I will show you what I mean. So group A and all these things have been published in the literature. Group A basilar invagination means when there is manifest atlantoaxial instability. Instability can be seen, atlantodental interval is increased, so you can see the instability. Like here you see the instability and you see the facet. There is facetal listhesis, atlantodental interval. This is group A basilar invagination. There is Chiari malformation. Group A basilar invagination is a chronic kind of situation. Group A is a rather acute. Group B is chronic. So this is facet of C1 is in front of C2, and there is Chiari malformation, relatively rare problem. There is Chiari malformation. There is basilar invagination. You see the facets are in alignment. Facets are in alignment. Even this situation, so the concept is, even when the facets are in alignment, it is an unstable situation and they merit the need for atlantoaxial fixation. So this is basilar invagination, there is some mobility vertical, there is Chiari malformation. You see the facets are in alignment, atlantodental interval, there is no problem. These patients have Chiari malformation syringomalia. They do not need decompression. They need stabilization. So this is my concept. This is another case of basilar invagination, syringomalia. Another thing I want to show you, you see all my slides. Posterior fossa is not tight. There is huge amount of CSF in the posterior fossa, in front of the brainstem, behind the cerebellum, around the spinal cord. Syringomalia, post-operatively you see syringomalia reduced in all patients. In group B basilar invagination, which is a relatively different, it was understood differently, we say now for sure atlantoaxial instability is the cause and stabilization is the treatment. Basilar invagination group B, and you see we introduce another kind of facetal instability where C1 goes behind C2. C1 goes behind C2. So this is group B kind of instability needing stabilization. No decompression is required. Basilar invagination, you see the facet of C1 is behind facet of C. This is an unstable facet. There is no atlantodental interval problem. So we introduce one different parameter, that atlantodental interval is not the only parameter. There are other indicators of basilar of instability that need stabilization. You see syringomalia, Chiari malformation, the facet of C1 is behind facet of C2. So this is type 2 kind of instability, meriting the need for stabilization, no decompression, and syringomalia reduced. Most importantly, and you believe me, patient will improve in the evening of operation and not marginal, remarkable clinical recovery. You see there is Chiari malformation, facetal instability, facetal fixation, and the treatment. And I want to show you some kind of videos. Can you put this video on, please? Unfortunately, maybe I wanted to show you this and simultaneously put the other one. Time is the issue. Suri is sitting and Suri is shaven head like Mogambo. And you see this is immediate, within 1 week of this thing, how this lady only fixation. And I have not one case. I am having now, I am doing 200 cases of Chiari malformation in 1 year. Can you believe 200 in 1 year, last year? All from all over the world. And I am having various kinds of issues. So there is Chiari malformation. There is, you see, no tight posterior fossa, only fixation, facetal instability is the issue. Show quickly, Mogambo. This is also after about 3 weeks of surgery. You see this guy is not able to walk also properly, and if this fellow is now smiling. And I can tell you, my dear friends, smile will come in the evening of operation. All the symptoms will go. If I say like this, don't you think I have not done any decompression? This is another case, Chiari malformation, syringomalia, and there is a fixation. There is now, you see, preoperative syringomalia reduces, no facetal instability. Syringomalia, huge amount of syringomalia, syringomalia reducing. I am saying again, reduction of the syringomalia is not an issue. Improvement of the patient is an issue. But again, I am saying, syringomalia will certainly reduce if you do after 6 months imaging. I have got reduction in the immediate post-operative period also. You see preoperative and post-operative, no decompression, no bone decompression, no dural decompression. And most important is not the reduction of syrinx, not the reduction of syrinx, not the tonsil going up, but the clinical recovery of the patient, remarkable. And that you have to believe. The other thing is, other fantastic thing is, you think about it. And I want to show you cases where the patients have failed posterior foramen magnum decompression. Failed means you do foramen magnum decompression, failed. And this is the patient. And he's an IIT engineer and a fantastic, show quickly, Mogambo, quickly. Now you see here, this is preoperative. There is a Riles tube. He has undergone foramen magnum decompression, several shunts and CSF leak and meningitis. And this is within 2 months of surgery. An IIT engineer, now I hear from him that he wants to go back to IIT. See, I'm not giving you an emotional kind of play. I am giving you a factual kind of situation. I'm not a private neurosurgeon or something. I'm in an academic institution. I'm giving you academics. Don't say, this is a possible this thing. This is another case. You see foramen magnum decompression. There is a shunt here. Now you see syringomyelia, shunt, and you see postoperative shunt reduced atlantoaxial fixation. When I wrote this paper, there were several comments, and I am facing these comments for last 5 years in a very fantastic manner. The whole Pediatric Society of North America, Pediatric Craniocervical, there were 20 authors here saying that no, we don't believe. Then I wrote this, my experience with 33 patients of Chiari malformation, and you see here, this is one patient, and show quickly, my dear friend, this pediatric child. Oh, my dear friend. Oh, Suri, did you tell anything? See, this is the child. Now you see, now don't see, this is not emotional run, my dear friends. Just try to feel that a revolution has been created. A revolution is here. You raise, one fellow raises hand, don't think that he will be, others will be, think about it. Maybe when you see rebuttal, and this is another fellow, he's also jumping around the place. And this jumping comes in the evening of operation without any decompression. So, Chiari malformation, syringomyelia is a neural manifestation of atlantoaxial instability. Torticollis, short neck, bone malformation, musculoskeletal abnormals are musculoskeletal responses to atlantoaxial instability. Chiari malformation is a nature's airbag. Chiari foramen magnum decompression is a historical operation. Is Chiari a formation or a malformation? My answer, you know, it is a formation. Thank you very much.